Welcome back to the IndeVets Happy Hour. We took a little break. We took a little break. I think we all needed a little vacation. We've been working so hard here at IndeVets.
I need more of a vacation.
You need more of a vacation?
Yes.
Yeah, I think we always need more vacation. Today is the 33rd episode, and we are so excited because we have two things. We're starting a brand new series, and we have a special guest who's going to be joining us on the entire series.
Very special guest. I'm so excited.
So, Marisa, why don't you do the honors?
All right. So I'm very happy to introduce Casey Robinson, DVM, to the podcast.
Yes, on my team. He's on my team.
An associate IndeVet that started last September with us and recently started training as our area medical director for an ever-growing area. An area I like to call the upper Midwest and Massachusetts.
How many states does he cover?
More than anyone.
Wow.
Yeah, so...
Should we let him introduce himself a little bit?
Yeah, Casey. So please give us a little background on yourself as a vet, where you went to school, when you graduated, and what you've been doing since.
All right, so I graduated from Oakland University in Rochester, Michigan, went to veterinary school at Iowa State, graduated in 2014, did a rotating internship at Blue Pearl, stayed on as an ophthalmology a specialty intern, was lucky enough to be granted a ophthalmology residency, which was great.
Wow.
Decided at a certain point that although I do love ophthalmology, I don't want to do ophthalmology all day, every day. Certainly missed other aspects of being a vet. Moved into general practice, worked at a few different practices in the Detroit area for a few years. Was lucky enough to find IndeVets when I was looking for a new role. I remember talking with you, Andrew, way back in, I think it was probably July, and have been just thrilled ever since and couldn't be happier to have started in the AMD role.
Yeah, you rose through the ranks pretty quickly, I have to say. We all loved you right from the start.
Perfect.
So absolutely, as we do with all of our IndeVets, by the way.
That's true. We have a great team, and we are expanding rapidly, like we said, but really excited by expanding rapidly and including Casey in this. We get to have multiple local beers, seltzers, and ciders. And so I'm really excited. I want to give a shout out to Danielle, our newest IndeVet.
She's listening.
She's listening. She's starting in Vermont, our first IndeVet in Vermont. She's starting in October. And she said, I love your podcast, but do you drink anything other than beer? And I was like, great point.
Whiskey.
Sometimes we drink whiskey, Danielle. But in honor of you today, I am drinking a local Philly hard seltzer called Two Robbers. And I was recently informed by my brother that the two guys who own this seltzer company their names are Vic and Viv. And the reason they named it Two Robbers is because their place was broken into twice. So sorry, shout out to Vic and Viv, but no beer for me today. And representing the Northeast.
Oh, yeah. So I took your advice, Danielle, and I went out and bought some ciders. Couldn't find a local cider that was cold. So I went with this New England cider, actually. So sort of in your neighborhood. It's called Down East, and it's called Unfiltered. Pretty good. This one happens to be the blackberry flavored cider. So, yum.
And straight from Detroit, Casey, what are you drinking?
So I'm drinking Two Hearted Ale from Bell's, which is, in my personal opinion, this is our flagship Michigan beer. Just a solid go-to. You can never go wrong with Two Hearted. For IPA lovers, always a good order.
I agree. I've been there and I've had it and it's really good. So anyway, all right. So we have 6 eye topics. I'm going to go through them real quick and then we're going to jump in. But the first one is the glaucomas, which sounds really scary and like
It's like the villages.
Yeah, it's like a villain. Sounds like a villain. But the glaucomas, we're going to do KCS, feline ophthalmology, the ophthalmic workup in general practice, corneal disease, and eye medications to keep in-house for your general practice. So just like we do in all of our podcasts, we like to say we're all general practitioners. We are not specialists, and this podcast is directed towards general practitioners. So anything incredibly special or research-oriented, you would have to dig into a little bit further. But we are not specialists, and we cater to general practitioners.
Although I will say that Casey does have much more knowledge about this stuff than the more common general practitioner, I will say. So, Casey, let's talk about glaucoma. What's the best way to recognize and diagnose glaucoma?
So, I mean, honestly, Glaucoma can be recognized in multiple different ways. I think coupling your clinical exam, ophthalmic exam findings, and history is super important. You can roll in things like breed disposition, age, signalment type things, but at the end of the day, any dog of any age can get glaucoma. I've seen glaucoma in an 8-week-old puppy. And then you see glaucoma in the 15-year-old dog. St. Bernards, Chihuahuas, all over the place. Granted, there are certain predispositions to keep in mind, but for me, clinical signs are going to be my hallmark. And that starts the moment I enter the exam room. Looking at the dog. Is the dog squinting? Is there any altered mentation, altered behavior? Can the dog see? That's honestly probably one of my huge things that people often forget about. Is the dog acting painful? How does the eye look? Is there any episcleral engorgement or scleral injection, some people will call it? Is the cornea cloudy? Is the eyeball big? If the eyeball is big and it ends up being glaucoma, we've got some serious problems.
Yeah.
Looking a little closer into the eye, you can see little stretch marks in Descemet's membrane called Hobbs striae, which just are lighter blue lines in the cornea. Looking closer into the anterior chamber, sometimes you'll see that it's shallow. There are scenarios where it can be deep, but I'd say more often than not, you're going to see more of a shallow anterior chamber. You're going to see most of the time, a fixed dilated pupil. That's going to be another hallmark. If you see that huge big pupil with a cloudy cornea, I'm almost having to talk about glaucoma before I even take a pressure.
Good point.
Chronically, you can see changes to the lens, luxation, cataract formation. If you can see the fundus, you might see cupping of the optic nerve, and then chronically just overall degeneration to the retina itself. It's interesting how it forms too, because the pressure is so high that the endothelium can't actually pump water out of the cornea.
I always hear people talk about this optic nerve cupping, right? And as general practitioners, we're not great fundic examiners. And so if you had to kind of describe what that looks like, can you do that?
It'll look much darker than your normal. The periphery of the optic nerve will look a little fuzzy, but that's really hard because you'll be thinking sometimes you can see optic neuritis look like that. But in my experience, the nerve itself, especially the periphery, looks darker than your normal optic nerve.
That's really helpful because that's always hard for me.
You have to see it a lot to actually appreciate it. It's really cool to see the histopath images though, because the optic nerve is just pushed back considerably far as opposed to being flush.
Interesting.
Like normally is.
Yeah, you're right. I probably would have to see a bunch of pictures of that. Anyway, I know you said any dog can get glaucoma at any time, but are there any breed dispositions that we see more frequently? For sure. So, this is of course not all inclusive, but I think if I were to make a poster about glaucoma, I think I might put the Basset Hound on the which my wife wants a Basset Hound, and the first thing I'm like, no. I don't want to give eye drops 25 times a day. Yep.
The American Cocker Spaniel is a big one. The Boston Terrier, the miniature Schnauzer, the Chow Chow. Beagles are actually very interesting. They've been kind of like the classic model for glaucoma research, and they're one of the classic breeds that will get open-angle glaucoma, similar to humans.
My sister has a Bouvier de Flanders, and it also is predisposition, and it did get glaucoma.
Yep.
So if you're listening, Stacy, my sister, shout out.
Didn't you say that Bouvier lost both of his eyes?
Yeah, he did lose both of his eyes. 6 months apart, which is almost like textbook.
Yeah, it's so quick.
Yeah.
Yeah. All right. Interesting. So we know there's different types of glaucoma. So can you go over that a little bit?
So honestly, I think there's two main ways to break it. There's primary and there's secondary. Neither are good. Glaucoma, as a general rule, sucks. It's the worst. But to say a dog has glaucoma is like saying a dog has cancer. There's so much more that needs to be said about it. So I'll start with primary, I guess, would be the first one I would talk about, then move into secondary.
Okay. Sounds good. Yeah.
All right. So primary open angle. I can't say that I've honestly seen this more than one time. And I think from a general practitioner standpoint, it's somewhat semantical, but Primary open angle glaucoma, and this is similar to what the humans will get. They'll get more of an open angle glaucoma. You're going to see this in the beagle and in the Norwegian elkhound commonly. This is going to be that slow onset, slow increase in intraocular pressure type of a glaucoma, traditionally bilateral. You're going to see this in your young to middle-aged dogs. Initially, when you actually look at the iridocorneal angle, it's going to be open. Progressively, it will close. Then the eye will become ophthalmic, and then the lens will luxate, and it goes to hell in a handbasket. But initially, it is open. I think that's the hallmark to the actual disease process. The mechanism is relatively unclear, but overall, it's thought that there are biochemical abnormalities happening at the level of the trabecular meshwork, leading to greater resistance to aqueous outflow and thus an increased pressure. Honestly, at the end of the day, for a general practitioner, prior to hopefully they're open to referral to an ophthalmologist, but treatment is essentially identical to the second thing would be primary angle closure glaucoma. This is the one that we're going to be more, when we see a primary glaucoma case, we're going to be more accustomed to seeing. This is that rapid, unilateral, progressing to bilateral type event. This is going to be your middle to older age dogs. It's going to be, honestly, I believe it's 2-to-1 female to male ratio. So females are certainly predisposed. One of the really unifying findings we'll see with angle closure glaucoma is goni dysgenesis or pectinate ligament dysplasia. And you can find some really good images of this in textbooks, even on the internet. Just the actual flow hole becomes smaller. Traditionally, your pectinate ligaments are going to be nice, gentle, and fine around the entire 360 of the iridocorneal angle. And they become these thick, broad pieces of tissue that just don't flow. I like to honestly think about the eye like a sink. You have your faucet that's producing the aqueous, and you have your drain that's draining the aqueous. That's always a really, really good. And most exam rooms have a sink, right? So I turn the faucet on, and that's a really good way to discuss just the disease process overall with clients.
That's a good point. And so I have a couple clarifying questions. So
yeah,
I don't think, right, I would be able to see an open angle glaucoma, right? Like what would I wouldn't be able to like visualize that with my ophthalmoscope if I were like,
no,
right?
No.
Okay.
I've met one guy, Dave Ramsey, who practices out of Williamston, Michigan, who's just one of the smartest human beings I've ever met in my entire life. But he is actually able to look at the iridocorneal angle with his indirect lens. 99.9% of people that I've worked with otherwise have actually had to use a gonio lens, which is a very specific lens you'll place on the eye that will bend the light and will allow for a better examination of the angle itself.
Okay.
That's nothing that I have ever seen in any general practice ever.
Right.
And so, Casey, is it important to know the difference for treatment options? I know we haven't gotten to treatments yet, but like when thinking about treatment of glaucoma, if you know that it's open angle versus closed angle, does it make a difference in your treatments?
I don't think so. And it really doesn't make a difference for the general practitioner that's diagnosing and initially triaging the case.
So it's almost academic at this point, just to know the differences, but no general practitioner is going to be able to diagnose whether it's open or closed.
If you're a betting man,
go with closed.
You should put your money in closed.
Right, unless it's a beagle.
But
unless
it's a beagle, and then if you're right, you look like a rock star.
There you go. Awesome. Great tips. All right. Secondary glaucoma?
Secondary glaucoma. So there's two types of secondary glaucoma. There's secondary open angle glaucoma and secondary closed angle glaucoma. An open angle glaucoma is going to be a normal iridocorneal angle or drain, but it's just filled with stuff, inflammatory debris, blood, you name it. That's like putting a paper towel into the drain. Gradually, that angle can narrow and it can become a secondary closed angle glaucoma. Secondary open angle glaucoma carries a far better prognosis because you simply don't have those anatomic changes that you have to fight with going forward. We could go through the list of secondary causes of secondary glaucomas, and the list is quite long.
What are the most common?
I'd say in my experience, I'm going to see lens luxations causing and those come in in my experience, a really high pressure. When you have a dog with like a pressure of like 70 or 80,
Yeah.
I'm really making sure there's not a lens sitting there. Iris Bombay or any type of synechiation would be another super common one. Intraocular neoplasia is a big one. Hyphema. Those would probably be the most common ones.
Yeah, I was gonna say I was just recently on a trip on a RAVS trip, and we saw this dog who had trauma to his eye, blue eye, total hyphema, and glaucoma, and everything else about the dog was perfect, but we knew that he had gotten in a fight, and so trauma first, and then secondary glaucoma, unfortunately.
Secondary glaucoma.
Yeah.
Did you enucleate the eye?
It was going to get a new.
Someone was
yes.
going to do it. Okay.
Yeah, absolutely.
Intimacy cataract, that would be another one too. Like your diabetic cataracts, that would be something. Usually uveitis is at play there as well, but that would be another common one.
Yeah, awesome.
But so did you also mention detached retina, or is that not a cause of secondary glaucoma?
I believe that generally that's going to be the secondary uveitis from the retinal detachment, causing that inflammatory debris to clog the angle.
All right, so how do we diagnose this disease in general practice?
Honestly, I'd say a lot of the cases of glaucoma I see have been diagnosed by the time I examine the dog. I think the clinical signs are so important. History is so important. If we're looking at actual diagnostic tools, tonometry, looking at intraocular pressure. Traditionally in general practice, most people are going to be either using applanation tonometry like the TonoPen or rebound tonometry like the TonoVet. I'm personally partial to the TonoVet just because you don't have to calibrate it. The TonoPen, but they both give you great. So dogs, compatible clinical signs with a pressure of over 25, consistent with glaucoma. Cats, over 27 with compatible clinical signs, consistent with glaucoma.
How frequently do you see this in cats?
I would say it's certainly not as commonly in dogs. And again, cats are going to they have their own thing going.
Yeah.
Honestly, I'd say fairly commonly, and it's frustrating because not all the medications work the same in the cats as they do in the dogs. I'd say unifying for both is owners aren't going to really notice a lot of these clinical signs until fairly late in the disease process. Like when the pressure's over 40 is when the owner's going to notice that change. And I believe that pressures over 40 have been described by humans as the worst migraine headache I've ever had.
Wow.
So you can kind of translate that to our veterinary species, and it's a painful disease.
Yeah.
Rules change a little bit when you're treating a patient with glaucoma or there's another disease process going on. Like if a dog has anterior uveitis and the pressure's 20, I'm worried.
Oh, yeah.
If I'm treating a dog for glaucoma and the pressure's 21, I'm worried. So you really have to tie these things into a story and not just rely on your one sole pressure.
That's a really good point. So you mentioned two types of diagnostic equipment that we can use in general practice. And you're right, those are probably the two types that I see the most commonly. So TonoVet versus TonoPen. And I know both can be pretty frustrating to general practitioners. So do you have any tips or maybe how you use each of them pretty quickly, or any tips you've developed over the years?
The initial learning curve for the TonoVet is a little steeper, but I think it's just harder to screw up as long as your probe doesn't fall out, which happens to me on the regular.
All the time.
Yeah. So I think that's one of the reasons I like the TonoVet. I know people that work with equine don't like it, but that's for another day.
No, we're never talking about that.
Horse eyes. I think one thing that's always important to think about when you're taking pressure with a TonoPen is if there's like a really big like area of scarring in like a pug, aim for the area with the least amount of scarring.
That's a good point.
Don't take it right on that big pigmented area in a pug. I know there are studies that say that can alter the pressure. If there's an anterior lens luxation, do your best to not take your pressure right where the lens is touching, because you're going to get a higher pressure than it actually is. But at the end of the day, pressure's high. It's not going to 100% change what you do from there. And always trying to have that lowest percentage of air on the TonoPen is important as well.
Also, I remember when your technician is holding the dog, if they put too much pressure on the neck, they can also increase the pressures by a few points as well, right?
Super good point. Holding the neck. I take the collar off of every single dog that I take the pressure on. No dog gets a pressure with a collar on. And another thing to think about is when you're actually holding that eye open, making sure that you're putting the pressure on the actual orbit to hold the eyelids open and not pressing the globe.
Good point.
That's a great point. You don't even think about that because
Sometimes
you're
it's
just
just
like,
so
I
hard.
just need to get it
I know.
done.
It's just so hard to get them to sit still
I
and
know.
to allow,
It's
something
true.
coming right at their eye.
It's true. Okay, so you've diagnosed it. Primary or secondary glaucoma. Now what?
So you diagnosed it. I think the other diagnostic modality that we kind of already touched on is gonioscopy. Nothing we're going to be doing in general practice, but that's going to be the actual visualization of the angle. So now once it's diagnosed, there's literally one question you have to ask yourself. I guess two questions. Is the eye visual or avisual or non-sighted? Some people will say. Is it acute? Is it chronic? The answers to those two questions are going to drastically affect the way you move forward. 24 to 72 hours of elevated pressure, you can have irreversible vision loss, and you're having a very different conversation with the owner as opposed to, I woke up and it was like this. Those are completely different days, completely different conversations. So is the eye visual or non-visual? How long has it been going on? That is super important, right up there with, is it primary or secondary?
Awesome.
I have a question about diagnosing. So for IndeVets, we go to a lot of different practices, and sometimes they don't have an instrument to take a pressure reading. So sometimes they don't have a tono pen or tono vet. And the normal eye exam, normal ocular exam would include, pressures, tear testing, fluorescein testing, right? All those things when you're doing the full eye exam. Like, at what point must you send them off somewhere else to get a pressure? Like, what are certain things that you see that you're like, I don't need to get a pressure here versus I do need to get a pressure, right? Like a red eye, do you almost always send them somewhere else?
Ideally. I mean, you could certainly make an argument because digital tonometry is a thing. The pressure between the right and left eye should not differ between more than 20%. So if you have your clinically normal eye that has some give to it, then you have your affected eye that's like a marble. Maybe you have tear tests and it's tearing like crazy, artifact of pain. I think you haven't, along with your clinical exam findings, I think you have enough to say glaucoma is by and large my top differential. But I guess at the end of the day, I would worry about the time it would take to send that patient to another facility. Time is of the essence. It's just like a back dog.
Yeah.
The clock is ticking. So I think you're going to do much more harm by waiting than you're going to do by taking action in those scenarios.
So if you have a hunch, start treating. Even if you don't have even if you don't have a specific reading.
I personally would. And I guarantee there are people that would say that guy's crazy. But if I'm checking all these boxes for glaucoma, if the eyeball is hard as a marble.
Yeah.
Now, is my medication choice going to change? You betcha. If I can't see if the lens is in place, the medications I reach for are going to differ than if I can say, yeah, that lens is posterior to the iris. I'm going to hit it with everything I've got. But I think that there are certainly situations where you will, by waiting, you could be behind the eight ball, especially right now with scheduling, how, in my area, ERs have 4 to 6 hour waits and eyeballs are not going to be at the top of that triage list unless it's maybe hanging out. There are certain, maybe, but I think that if you feel comfortable and you have enough of a leg to stand on without an actual number, I don't think there's many people in the room that are going to shake their finger at you.
Yeah.
Well, let's get into the treatments then.
Yeah. So there's two different wings. There's medical management, which is by and large going to be what the general practitioner has to focus on. And there's surgical management. In a perfect world, upon diagnosis, we marry those two things. But the initial endeavor is almost always going to be medical. Both surgical and medical approaches aim to do one of two things: either decrease aqueous production or increase aqueous outflow. That's literally the only way to decrease pressure, those two options. So medications try to take advantage of that. So you have things like timolol, like durzolamide, so a beta blocker and a carbonic anhydrase inhibitors. Those are going to be your decrease aqueous production or try to shut off the sink in the sink analogy. Now, when you look at our carbonic anhydrase inhibitors, a long time ago, there were I don't think I've seen anybody use any systemic carbonic anhydrase inhibitors, maybe ever, but I'd say dorzolamide or brinzolamide are going to be the most common ones that are used. Then there's a great product like Cosapt that is dorzolamide and timolol all in one drop. Basically, that's my favorite drop. That's your best chance to turn off the sink. Then you have your prostaglandin analog. And I think the most common one we're going to know is latanoprost. So that's going to be increasing outflow, basically the unconventional outflow pathway for aqueous. That one is a little touchier because there are contraindications. The two big things are, A, it's a prostaglandin as part of the inflammatory pathway. So should we be using this willy-nilly in super uveitic eyes with tons of inflammation? You can, and if you're desperate, you can't get it down, but I'm probably not reaching for that in a really, really bad secondary glaucoma from uveitis. But I think the big hallmark one where you should not grab latanoprost is going to be in an anterior lens luxation. The pupil is going to become myotic. You don't want to further trap that lens in the anterior chamber by closing down that pupil.
That is a good point. And do you have to, are there any contraindications? Maybe someone scared me about this when I was a younger general practitioner, but any contraindications to timolol or the beta blocker if the animal has like an underlying cardiac disease or anything like that?
I remember in ophthalmology in school at Iowa State, the rule was eschal everything that goes on timolol. I think the concern becomes higher in cats.
Okay. A,
because cats can have those very annoying underlying cardiomyopathies that can be easy to miss. And the dose becomes an issue because of size. If it's a 5-pound Chihuahua, it'll be a thought I have.
Yeah.
I don't think timolol is ever going to be your make or break medication.
Okay.
I think your carbonic anhydrase inhibitor or dorzolamide is going to be your big guy.
So if the glaucoma is caused by uveitis, what other eye medicines can you use in conjunction with these medications you're talking about now?
Anytime you have that primary cause, you do your best to address. I'm a huge fan of prednisolone acetate for uveitis. 1% predacetate. It can be expensive, but I think it works better than something like a Neopolydex or dexamethasone in general. And I'm definitely not above. A lot of people will think, oh, I can't use an NSAID and a steroid at the same time. I do it ophthalmically all the time. I will frequently couple a predacetate and a diclofenac to combat really bad inflammation.
That's a good pearl.
Do it all the time.
Okay, so I actually have a question about medical treatment before I ask a different question. If you have extremely high pressure and there is no way the owner can refer and there's no lens luxation, what is the medical treatment that will bring the pressure down quickest, possibly?
Again, this is nothing that's documented, but there were two things that I would do, especially during my internship when I was working emergency, to bring the pressure down. I would do 3 rounds of latanoprost, 5 minutes later Cosapt, latanoprost, 5 minutes later Cosapt, latanoprost, 5 minutes later Cosapt. I'd do that, so the 3 times. And I would recheck pressures in an hour. If they weren't better, you can either continue to try that, which I never did, but you can do an aqueocentesis or a paracentesis. It's risky. The 2 things you have to, you risk, what if I hit the iris and the eye fills with blood? And definitely worse, what if I hit the lens?
Yeah.
And then we get a phacolytic uveitis. It's game over if you hit the lens, and it's whoops if I hit the iris. But at that point...
That's what I was going to say. At that point, it may not be... Salvage. It's a salvage almost, especially if you're like in a rural practice and you can't go anywhere. I would probably try to do that.
Yep. I do it frequently. There was one time there was a student shadowing me during one of the previous practices I was at. I did a paracentesis, and she watched an aneurysm earlier in the day, and the paracentesis made her pass out. That was it.
I mean, needles in the eye are bad. I agree.
It's bad. A few tips for a paracentesis, if you are so bold: go in right at the limbus, about a 45-degree angle. Make sure you don't just accidentally just poke right into the stroma of the cornea. It's actually very easy to do if you don't go at a sharp enough angle. Obviously, make sure you don't hit the iris of the lens. Bevel up. Always bevel up. And I always try to make sure that I don't, or I do my best to make sure the needle doesn't enter the visual plane. Because if that dog does have some residual eyesight, which probably if you're doing a paracentesis, it doesn't, but the actual visualizing that needle coming into their plane of vision can freak them out. They buck.
Yeah.
And then you enter one of those other scenarios that are no good.
And I'm assuming you've numbed the eye with proparacaine at this point?
Numb and some dilute betadine.
Oh, yeah.
Dilute betadine.
And probably some, pain medication, like an opioid or something, injectable.
I will probably have given them like a buprenorphine injection or something like that.
Yeah.
And I will do I'll always have a speculum in. And a really good way to really, really make them not feel it is soak a sterile cotton swab in proparacaine and actually hold it against your entry site. Hold it there for 15 to 30 seconds.
Yeah.
That will really help numb that area.
I mean, as a younger vet, I was so much more cavalier, and I worked with a doctor from CARES, and she actually is the one who taught me how to do a paracentesis.
Yeah,
and
they were
I
big
was
on
like,
them there.
Yeah, I was like, this is great. I'm gonna do this, and then now I would not do it probably unless it was obviously a salvage procedure. But those are very good pearls. Thank you.
Yeah, absolutely.
How about non-medical management besides paracentesis?
Oh, another thing that I will always do in my acute glaucomas, I always put them on some sort of anti-inflammatory, pardacetate or diclofenac.
Okay.
That elevated pressure will always invariably cause some degree of inflammation. We have to address that.
Hold on one second. What about systemic meds? Anything?
I like NSAIDs.
Okay. Yeah, that's what I thought too.
And another huge thing that I need to mention is if we have a primary glaucoma, we know that it's a bilateral disease. That contralateral eye needs to be evaluated and needs to be prophylactically treated. I personally like to either use timolol or dimecarium bromide long-term. So dimecarium is miotic that will open up that angle as much as possible, but I like timolol. I asked a ophthalmology friend of mine, hey, do you ever use carbonic anhydrase inhibitors as a prophylactic medication for predisposed primary glaucoma eyes? His answer was, I do whatever I want. So
all right.
If that tells you anything,
all right.
Go more aggressive. But yeah, that's just one little thing. And then after that, I will monitor that eye once a month for 3 months. And then every 3 months thereon out. Once it gets above 20 or above, then I start to get nervous. But anyways, Marisa, to circle back to your surgical intervention, it's the same thing. Essentially, we either want to encourage aqueous outflow or inhibit aqueous production. Encouraging outflow, you could make the argument that an aqueous centesis would be an encouraging outflow. I guess I would consider that surgical/rescue. But I've seen eyes go back up in pressure within 4 to 6 hours after centesis. I know that there are some that think that medications will work better when the pressure goes down. I'm not sure if there's actually a study on that. So to encourage aqueous outflow, that's going to be your Ahmed gonio implant. They're super cool. They basically gets sutured to the sclera, and then a little tube gets put into the anterior chamber, and aqueous gets to flow out. There's a relatively high failure rate. There can be inflammatory debris that clog up the tube, and there can be fibrosis that will clog up the tube. People will do things like, use mitomycin C or some kind of antifibrotic to prolong the use of that. But I don't think I've ever seen anybody use a gonio implant as a sole surgical intervention. It's always going to be in conjunction with something like a cyclophotocoagulation, so laser therapy.
Thank you.
I know me and Andrew were mentioning this.
I was like, what?
And by the way, I've seen it done, and it was on a basset hound, by the way. I know you mentioned a basset hound at the beginning. So.
Basset. I'm going to have my wife listen to this podcast so she can realize that we should not.
Many reasons why not to get a basset hound that I can tell Aaron about.
The smell alone.
I even remember her name. Her name was Daisy.
Of course her name was Daisy. Every basset hound's name is Daisy.
Yep.
That is true.
Right?
My aunt had a basset hound named Daisy.
What is that? Anyway, sorry. I digress.
No, you're fine. So previously it used to be transscleral, where they would actually just put a laser probe at the limbus and at the point of the ciliary body and destroy the the ciliary processes from the outside. Where I did my internship and partial residency, they were doing endolaser, actually entering the eye with a laser probe, visualizing the ciliary body processes, and destroying them with a laser. It can be hard because you have to know how much to actually destroy. If you don't destroy enough, the pressure stays high. If you destroy too much, always remembering that a lot of the portions of the eye rely on aqueous for life, the eye becomes phthisical and they get thesis bulbi and it's game over. So it's a very, very delicate balance knowing how to approach that particular procedure. But I know for a fact that at the end of the day, that is going to be your probably best chance for surgical success. It's going to be pairing endolaser with a goni implant.
Got it. All right. Well,
So that's switching off the faucet.
That's going to be turning off the faucet and opening up the drain.
so what if you can't do any of those things, aka because there's no ophthalmologist and it's impossible to get into one and a lot of people can't afford it? What are some end stage procedures?
End-stage procedures, say you've capped them out. So you get your latanoprost at 3 times a day and your COSAPT at 4 times a day, and you're still in the tubes. Then we talk end-stage procedures. And personally, I think there are 3, 2 of which can relatively easily be performed in a general practice setting. There's the enucleation, which we're all very familiar with. It's one of my favorite surgeries, just mainly because whenever I take an eyeball out, I know it's going to be it's a source of pain, and the dog is always just, surgical pain is so far outweighed by the pain of the disease process that the dog is just happier than you can imagine.
Like
after
day
surgery.
1, right?
Yeah, like when they wake up.
Yeah.
They're so happy. There's the chemical ablation, which is going to be a cyclophotodestructive. I'll usually do that with basically an intraocular injection of gentamicin, because gentamycin's toxic to the ciliary body or the ciliary processes. And then the thing that needs a little more specialized equipment would be the evisceration with an intrascleral prosthesis. A lot of people like them. I find them I'd rather just take the eyeball out, but you actually basically remove all intraocular contents, keep the shell, put in a big marble, sew it up.
Weird.
Yeah, a lot of people really like them. My argument is always like, so now we have a non-functional eye. The dog doesn't really care. The dog can still get a corneal ulcer. The dog can still get dry eye. It can still have all these things that nobody wants to treat. If you have an eye that can't see, that's the eye's one job. Take it out. That's my personal opinion. Okay. I'm very pro nucleation for those.
Same.
Yeah. My sister's dog, the first eye they enucleated, and the second one they injected.
Yeah.
Just so that he had one. So they could see if he was awake or if he was asleep.
That's fair.
If they knew that he had this one removed, they still couldn't save the other one, like with meds?
No, they tried everything.
That's
insane. And she was seeing specialists too.
Yeah.
So they did everything. But they warned her. They said, this will work for as long as it'll work. And she did all the drops that you were talking about. She was maxed out. I think she was doing 4 times a day at least.
Yeah.
And she was so worried that he was going to lose his vision, but he did.
I actually think that's a really good question to piggyback on. And I remember because you responded to one of our doctors who asked this question on Teams, how frequently, obviously when you look in Plum and we start all these meds, it's 2 to 3 times a day, every 8 to 12 or whatever. But what is the max? If you can't get something under control and they can't refer, do you just keep giving it? Or how frequently would you say you could give it to try?
So I don't go above 3 times a day on latanoprost.
Okay.
I actually helped with the study that showed that even going from 2 to 3 times a day was of minimal benefit, but it still helped. Okay. But you didn't get near the benefit from going from 2 to 3 as you do from 1 to 2.
Okay.
And I don't go above 4 times a day on COSAPT, especially in cats, because you do risk a hypokalemia.
Got it. Okay. Great question. Answer.
Yeah, and you mentioned that cats don't respond as well to some of these meds. What are some of the treatments?
Yeah, let's talk about cats.
Yeah, now that Marissa's holding her cat in her arms right now.
So I think that there's a few main differences. One thing is And everyone, I'll be a broken record. People say this all the time, but cats are not small dogs.
Yep.
The rules change. Cats inherently run higher. A pressure of 26 in a cat, I'm calling that normal as long as the eye is normal. A pressure of 26 in a dog, I'm investigating further. I believe it's between 18 and 20 times more common for a cat to have secondary glaucoma than primary glaucoma.
Wow.
I think that primary closed angle glaucoma is nearly non-existent in cats. And I think that like Siamese are the one breed that can get an open angle glaucoma.
It's always the Siamese.
Yeah.
They get everything.
They got issues.
Yeah.
They get everything. Never get a Siamese. It's up there with the Basset.
Don't get a Basset, or a Siamese.
Yeah. Definitely a secondary glaucoma is going to be your top differential in a cat. I'd say there's one super interesting one I don't know if this is the entity in dogs, but aqueous misdirection syndrome.
What?
Basically where aqueous will be shunted posteriorly as opposed to anteriorly. So then that will basically push the vitreous and the lens forward. The hallmark there in cats is a shallow anterior chamber. If you see a shallow anterior chamber, like a really shallow anterior chamber in a cat with a high pressure, I'd be thinking aqueous misdirection syndrome.
I guarantee you somebody in our audience is going to find that in the next week now.
That would make me so happy.
I need to start looking more. How would I know if it was shallow or not?
Look from the side.
Got it.
It's like looking for, like when you're looking for like aqueous flare or something like that. If you look from the side, you can actually see the distance from the iris face to the cornea.
But would it be a problem necessarily if they have that issue? Like, is it definitely causing them a problem?
Yeah, that'll be a form of your secondary glaucoma.
Oh, it would be okay. Gotcha.
Yeah. The second would probably be uveitis. Now, as with all uveitis, there's neoplastic causes, there's infectious causes. I feel as though toxo is overrepresented in infectious uveitis in cats.
Mm-hmm.
Neoplastic causes would be like a diffuse iris melanoma, a uveal lymphoma. Those would probably be the two most common. So I guess kind of uveitis and neoplasia are somewhat married there. A big difference in treatment is latanoprost does not lower pressure in cats.
Interesting.
It will cause meiosis, but it does not lower pressure. I'm fairly positive that brinzolamide, which is another carbonic anhydrase inhibitor, did not work terribly well in cats. That's why for cats, I would definitely go either just 2% durzolamide or a Cosapt, if there's no cardiovascular concerns.
Okay.
Great tips.
So carbonic anhydrase inhibitors in cats can produce a statistically significant hypokalemia. I don't know if it's a hypokalemia that's going to be noted in any other way than by running blood work, but it is recommended if you have a cat on a routine durzolamide to regularly check blood work. I don't think you need to go anything more than, say, every 6 months. And then obviously warning them and warning owners and telling them what to watch for hypokalemic events.
Interesting. Great tips. All right. And lastly, let's talk about monitoring once you get these dogs and I guess cats on meds. Let's say it's not end stage, obviously, but how frequently are you monitoring these guys?
It'll depend on number one cause, and it will depend on how they were doing last time. But especially for long-term monitoring for primary glaucoma, I will do once a month for 3 months. If I'm happy, pressures are below 20, I will do every 3 months, and obviously with considerable counsel to the owner for things that they need to watch for. And owners are usually pretty tuned in to what to watch for because they've experienced it before. The blue eye, the red eye, the squinting, running into the wall. But I really like the once a month for 3 months. Now, if I have a dog that comes in at 19, that's tough. I don't know if I'm going to wait a month on that dog.
Right.
Or if I see him, he has flare. I'm not going to wait a month on that dog. So I think it's going to really depend on where they're at in control of the disease process. What I'll say is glaucoma was my favorite disease until I started treating it more.
And then you're like, this is not good.
It's a bummer.
Yeah.
It's an absolute bummer. And I think that
because you can
it's
never
really
cure
tough.
it. You can never cure it.
You can't cure it. You cannot cure it.
Maybe with the
Yeah,
laser.
you can take the eyeball out.
Well, Well, I mean, you want to save vision, right? And I guess the cyclophotocoagulation is the closest thing you can do to curing it.
And a lot of times those dogs are on ongoing meds still.
Yeah. Wow.
That was awesome.
That was awesome.
I'm excited to have you on the next one.
I learned so much.
Yeah. No, it was a great refresher and certainly great pearls of wisdom. Hopefully all you doctors out there learn something. And for those of you who are not vets, you now know a lot more about glaucoma. It is different in humans, so don't take what he said and start thinking, oh my God.
Yeah, don't do it.
Very different.
Yeah. Next time we'll talk about dry eye, right?
Yeah.
KCS, keratoconjunctivitis sicca.
Oh my God.
Ooh.
Andrew likes to say big words. Awesome.
Makes me sound smart.
Thank you so much, Casey. It was great to have you.
Thank you for having me.
Thanks, Casey.
We hope you enjoyed this episode on the IndeVets Happy Hour. Thank you for listening. Tell your friends, and if you like us, leave us a 5-star review and make sure to subscribe so you can be alerted whenever we have a new episode. If you have questions, comments, or suggestions for future episodes, you can email us at clinical@indevets.com. Also, to learn more about us and how we're making vet med better, head to indevets.com. That's INDEVETS.com. While you're there, be sure to head to our blog for the latest stories and tips from our doctors. And lastly, if you're interested in joining our amazing IndeVets team, please email Dr. Andrew Heller at andrew@indevets.com. See you next time. Cheers.
I'm a veterinarian, sure, but I'm way more than that. I'm also a tango dancer, a struggling but determined pie maker, and a mom. With IndeVets, I get to choose when and where I work. I create my own schedule and choose shifts at nearby animal hospitals that are right for me. Having that flexibility is exactly what I need, so I have plenty of time for all those other things that I am. Because I'm more than just a vet. Visit IndeVets.com to learn more and apply.